The Central Club.
Okay, so in relation to what we're doing as a team nationally, what we are doing is we're hoping to go out to advert in the next couple of weeks to create a lived experience panel that will inform all of the work that we're doing across Wales and certainly inform the new iteration of the strategy. So we're really hoping by doing that we are able to, that person will lead on bringing together that panel and making sure that we have people with lived experience from all different areas so that we're really understanding the issues and making sure that we're considering these for the new strategy. So that's what we're doing nationally as a team. Who wants to go next?
You said strategy twice.
I did. I seem to love the word strategy today.
That's fine. Okay. Yeah, sorry. So I'm Julia Lewis. I'm a consultant in addiction psychiatry within the Aneurin Bevan University Health Board, and I'm also a visiting professor here. So the service that I'm the clinical lead for is an NHS complex needs addiction service. Everything has long titles, I've noticed.
Easy to spell.
Yeah. We used to be called Gwent Specialist Substance Misuse Service, which was very difficult to say. We're now an Aneurin Bevan Specialist Drug and Alcohol Service, which shortens down to ABSTAS, which is a lot easier. So within our service users are people with rather entrenched, chaotic addiction issues, and historically, addiction services have been set.
So sorry.
Oh, honestly, Cullen, you've got to get in on everything. Traditionally, addiction services have been set up as essentially heroin treatment services, and I could wax lyrical for hours about why that is. So most of our service users are people with sort of very heavy alcohol or heroin or increasingly illicit benzodiazepines and things like that, who have additional serious mental health needs or serious physical health needs, which is kind of a long-winded way of saying that we therefore end up with not too many people who are social cocaine or anything else users. Having said that, one of the things we do run in our service is a health worker service within our health board. So we run a separate service for people who are frontline health, police and social care workers. And it's a lot commoner within that group. And people are kind of coming forward for help. Mainly because they're being nudged by managers, and it's nice to see that managers are supporting them and not just getting rid of them. But from actually doing anything specifically directed at it, we're not. All our staff are nurses, doctors, support workers, OTs, psychologists that are all from a kind of a mental health background, but they've also all done the suicide assist training as well. And we've had a massive push on that recently to make sure that everybody in the service has done that. So nothing specific, which is, important in itself. So we're not doing anything specific, but staff that are trained to deal with people with suicidal thoughts and thoughts of self-harm as a natural part of their day-to-day job.
Okay. I was expecting to see Maggie then. Yeah. Neil Ingham. Maggie's been told off a few times this week for that. So Exec Director of Samaritans in Wales. I don't know, weirdly today I kind of wish I wasn't here for Samaritans, not because I'm not really proud to be here for Samaritans, but because, I don't know, just this morning it hits hard. And it feels like one of those days where you just want to be able to just speak freely. So I'll try and do that whilst being here for Samaritans. That could be dangerous. What are we doing? Top answer, not enough, or nothing specific really, although I think we've engaged with Maggie lots recently. So we had Maggie at the cross-party group for some suicide and self-harm in the Senedd recently, and I met with the chair of the substance misuse, drug and alcohol group on Monday. told him to get in touch with you, to get you on that agenda as well, to put you on the agenda. Samaritans, more broadly in terms of research and work we do, have done lots of work on substance misuse and alcohol, and strong correlations, as you would expect, between risk factors there, particularly for kind of addiction level use of substance, but nothing specifically on co-alc. But it's really clear to me, from all the interactions I've had with you and with Nicola and the others, that there's something here. And I think the previous speaker is starting to do the work to do the work that needs to be done to build that evidence base. But I do think there's some other stuff we're doing, and I think for me there's a massive overlap between the co-alc issue and men. Most of all the stories we've heard today are around men, and in a way that's kind of helpful, in a way it's not. So I'll try and explain why I think that's the case. So in terms of Samaritans in Wales, obviously males are much bigger suicide risk, and one of the reasons I came into this job was because that pisses me off, and I want to be part of sorting that out, as I know all Samaritans do. And I think part of the answers to that is to be way more granular. So I get really annoyed when people talk about men and males as some kind of generic group who are all at risk. I get no less annoyed when I hear that kind of broad level demographics are particularly at risk. So men in the construction sector are particularly at risk. To me, that's really unhelpful in terms of targeting services. And I'm really trying to get us working as Samaritans in Wales in a much more focused way, much more targeted way, to take all those risk factors and layer them on, and to start to think about who we really need to be working with and who we really need to be, who and when and how we need to be getting help-seeking behaviour in place and building resources around and getting services around. And that is really, really complicated. So it's also about recognising how complex this is. So listening to the three guys earlier on who were just amazing in all that they said, you're all totally different guys. Even before you opened your mouths, I knew you're all completely different. You're not men. You're three blokes, right? You're three guys. And all men are different. So the kind of generic thinking around how we get through to men, it takes balls to talk, all this type of stuff. We've got to get beyond that. And we've got to find ways to get to people, whether it's related to drug, co-alc use, or any other risk factor. We've got to find ways to get to people, connect with people, from Samaritan's perspective, hopefully to come to us or somebody else when they need us. When they're really at risk, and recognise how complex that can be and how challenging that can be. Because all the stories you shared, there's no easy way to find a way to get a service in front of you or to get you to seek help in those moments. So we have to recognise how complex that is.
Thank you. Yeah, I think from someone with lived experience myself, from that aspect, someone who's been engaging in services from the age of 18, over 10 years. My main focus was heroin and crack cocaine as well, but the crack was always overlooked as like a cocaine link. There's nothing really much we can do, but we can give you methadone or Subutex for your opiates. I've overcome that through whatever, but what I see now is my friends who I've grown up with who never used opiates but always used cocaine. I'm seeing a lot of them come to me for help, asking for help. I've got a problem. I've been kicked out by the missus. I've been on a 5-day bender. I can't do this no more. And they seem to be, they've come to terms with that they can't go to those services because they think it's just, there's no substitute for me. There's no this for me. It's just focused on heroin, like you said. And the other problem they seem to come up with is other services they go to tell them that they're too early in their you need to be clean for a bit before we can see you. There's no one actually with that problem they're going to, like, listen, I'm using right now, but I need help. Can you? And there's not enough of that is what I see. Would you agree with that? And what do you think about it?
Yes, I agree. What do I think about it? I think it's bollocks, right? And I am now 55 years old. I've worked in the NHS for a long, long time. I don't care what I say anymore. So thank you. Thank you. Like I say, what are they going to do? Sack me? No. I think the first thing is, when I was first a consultant in addiction psychiatry, I hated CMHTs myself. I used to get so frustrated with the fact that when I had patients, and I apologise, I call them patients, I'm a doctor, I can't get my head around much different. When I had patients that I felt had acute mental health issues that needed support, and they would go to the mental health services and they would say, we can't help you, you're using stuff, or you don't have a severe enduring mental health problem. And I used to get really pissed off about that and get worked up and, probably lose a few, grow a few grey hairs. What I've now come to realise is that mental health services, are completely strapped. And over the years, what's happened is that the core mental health services have been robbed of staff because of all these little specialist teams that have been set up. So the eating disorders team, the assertive outreach team, the early intervention service, they've robbed all the experienced staff so that the core CMHT is small, it's overworked, and actually what we see with people who have co-occurring mental health issues and substance use issues is that, no, they don't fulfill diagnostic criteria for that condition or that condition, but what they have is emotional distress. And it doesn't matter that you can't label it. It's still horrible, and people still kill themselves under emotional distress. And the CMHTs don't have an answer to that. The way they are set up is they are set to treat schizophrenia or they're set to treat bipolar disorder. We need a new approach, right? We need to work out how we can help people in those acute moments of emotional distress, which is then exacerbated so much by things like coke and alcohol and whatever, that it then leads to these horrible events, and I like the way we term them never events. They should never happen, okay? I can empathise, guys. I have stood by an intensive care bed with my stepson in it after he tried to hang himself, right? So I know what this fucking feels like, and it's horrible. These things should never happen. And to just turn our back on people, so I'm going for it now, aren't I? I'm actually on annual leave today, so I'm not officially here as a member of the NHS, so here we go. Thanks, Mags. No, you've got to do so. You can't say this service can't do anything for you, this service can't do anything for you. Then find the bloody service that can, and if it's not there, set it up. And that's what we need to be doing.
Thank you.
Just to add on that, I do think the services are available, and I do a lot of training across, I was going to say across parties then, but I do a lot of training within homelessness, housing, substance use, social care, mental health. And when you talk to practitioners, they know the issues. The expertise is absolutely in the room. I call for you to be professional troublemakers. If you're sat in a meeting and you're sat on your hands going, oh, I wish I'd said something, be that advocate for the people you're working with, whether you're a parent, whether you're for your mate, or whether you are, a commissioner in services. Like, be that person where they go, oh God, it's Charlotte again. Because that's when we get change. We know the pathways, we know the services, we have to do something different as practitioners.
Disrupt. We need disruptors.
Anybody got any questions they want to put to the panel?
I can come and give you the microphone. It's fine. Yeah? Come on. We'll come to you next. You've had enough, Paul. Okay. That's all right. Stand by here with you.
Hello, as everyone is in a troublemaking mood today, I was just wondering if anybody has any kind of ideas about legalizing drugs and the impact that may have. If you're allowed to say anything.
Okay. Oh, yeah, these are the ones answering. Yeah, sorry. Maybe I shouldn't have done this job.
So I'll half speak to it. So I'm not going to give a view on legalising drugs, so I do have one. What I do think, and this is not in any way a Samaritan's view, and this came out really clearly this morning, is we definitely live in a country where the reality of drug use, and we've talked about cocaine in particular today, versus the sense of taboo. And it was touched on earlier, this notion that, imagine going in for a one-to-one with your boss and them saying, oh, how are you doing today, Neil? And you go, oh, really, really rubbish. I had I'm on a downer after a hell of a weekend. Oh, a few drinks, was it? If you said, yeah, a few too many drinks on Saturday, they'd be like, oh, yeah, fine, but, get on with your day. Imagine if you said to your boss, in most employment environments, if you said, Yeah, I had a load of coke and booze on the weekends, took a few pills, smoked a few spliffs. Can you imagine? You would not have a job at the end of the week in many, many employment environments. And I probably don't need to characterise it any more than that. I'd like to think Samaritans as employer is actually probably not like that. Is it's not some sort of free-for-all, but it's very supportive, just for the record. But we live in this weird culture, don't we? We all know it. We all know that cocaine use is everywhere. It really is everywhere. And over the last decade, you just see that more and more. So the disconnect, I don't know how you address that, but I think there's an onus on services, on employers. Non-judgmentality is key. So right at the heart of Samaritans listening service, if you didn't know it, is just absolute non-judgmental anonymity. Anyone can call us. You're not going to get a lecture. You're not even going to be told what to do. So, expect me to sell that as an absolute offer that we can offer. And frankly, I think it's always going to be hard for statutory services to do the same. Although there's no reason they shouldn't be non-judgmental. I think inbuilt in the system are some of the ways that we treat particularly drug use and addiction is a sense of judgment or looking for a certain level of crisis before we'll intervene, which is hugely problematic. So legalisation, don't think that's really the issue. I think it's about attitudes and how we relate to each other and how easy it is to have conversations around this stuff.
You're not like to, Since the first cave person looked at the mouldy berries at the back of the cave and thought it'd be a good idea to try that, human beings have wanted to get off their bonces one way or another, okay? We have this perverse situation where one version called alcohol is legal and everything else is illegal. We've got to look at that sensibly, one way or another. And we have heard from the guys with lived experience today that actually the illegality is one of the barriers to talking about it, because you feel you can't go and talk to somebody about feeling shit coming down off cocaine, because the first thing they're going to say to you is, well, you shouldn't take it then. Right, it's illegal, shouldn't do it. So we've got to have a sensible conversation about it. You can soften the blow a bit by saying, well, let's talk about decriminalisation first, rather than going straight to legalisation. But one way or the other, that conversation has got to be had, because we probably are losing people because of it.
Just one more brief thing, and this was touched on by one of the guys earlier as well, is also, again, I'm not going to offer a Samaritan's view on this, but where you have the imbalance between drug use and then a kind of acceptance or even legalization of that, things like purity of drugs is a big issue. So we're all here talking about cocaine and alcohol today. I think it was put really well. We're probably not talking about cocaine and just cocaine in many of these instances, and that's kind of terrifying. It would be nice to know exactly what's showing up in the toxicology, because I'd imagine there's a fair bit in that toxicology that isn't just cocaine, and that has to be part of the understanding of this picture and part of the harm reduction and the approach you take to informing people and allowing people who are taking drugs to have that control and that power. If you live in a society where all of that is closed off, that's really problematic.
I do think the Drugs Act is quite ancient, though, to be fair. Yeah, Mike, no worries. It's your gig. I'm pretty sure you can.
I forgot what I was going to ask now.
She done that on purpose, didn't you? Do you want me to go back and refresh your memory? Shall I say that again? It's your gig.
Oh.
You got it?
Yeah.
See, that works, doesn't it?
Do you this is probably for Kerry, she's not going to forgive me for this, but with the changes coming up, the changes coming up on the new strategy, where they're looking at it now, it's in review. Do you think there's a good reason to add the use of alcohol and drugs into the national strategy?
Thank you. I did, yeah, absolutely. I think, absolutely aware. And it's really difficult for me. I can't tell you exactly what will be in that strategy. What I will say is that I personally am very keen that we acknowledge the use of drugs and alcohol and the risk of suicide. And I think my colleagues would agree with me. It's around how we do that. So it's recognising those at-risk groups. And so I'm not sure whether we'll have something specifically, for cocaine and alcohol, for example. But I think in terms of recognising those at-risk groups, I definitely think that substance use, will be included as an at-risk group. And I certainly think it's great to be here today, with the awareness that's being raised. And I think more and more people are developing an understanding, and that's fantastic. And particularly with the research that's being done, I know we've had these conversations a lot, Maggie, but everything is about, having that research to really understand. And I think the more we're able to research this area, the more we're able to understand, the more likely it is that we'll be able to really focus on this area, in our strategies. You're making me say strategy again and again as well, aren't you? I blame you for that.
What Julie was saying about things being in the categories, I think if we can get that, if we can have a strategy that does say drugs and alcohol, it might break down some of the barriers. Because what I've brought into the room today is people from one side or the other, and I think that's part of the problem. I think, the fact that we need to be working together on this, and that's why I've been so adamant about getting it onto the strategy, because I think if we are able to get these people in the room today that are talking about it, surely that's the way forward to making a breakthrough.
Absolutely. And what I'm really hearing coming out really strongly today is that need to really break that stigma around being able to talk about, drug use and so on. And we've been saying this for years about suicide as well. We need to be comfortable in talking about suicide and talking about suicide risk. And we need to break down some of that, some of those barriers. And we need to do that with drugs as well. So I think absolutely, there are kind of two parts to that conversation, and we need to include both. And I can certainly say from my perspective, that I'm going to be continuing to work with you, and through our lived experience panel as well. We really want to hear people's voices. There will be lots of opportunities to engage in the new strategy, and said it again. And so, I invite everyone to be part of that and to bring those voices forward, because that's the way for us to have that captured in that strategy. Yeah, and I've said it again, so I'll finish on the word strategy.
No, I'll just say quickly as well, I'm part of a project in Cardiff under CAVDAS Kaleidoscope, Voices Action Change, which is all about service user involvement and co-production. And we have loads of people come in, and some of them, again, are tied to where to engage. So we have lots of people with that lived experience who would love to engage in that. So 100%. Yeah.
Can I just get your views on when you think we've got this awareness, and we've got, these guys that have come today? I mean, I haven't had personal experience of that, but it really hit home. I've got a teenage daughter, and it really is hard for her. And, she had a terrible time with her mental health through lockdown. And the schools say, oh yeah, we've got this mental health support, we've got this mental health policy. But when it comes down to it, it's a piece of paper. So what's your view on, I think this education and this awareness should start younger, because it's not just, middle-aged men or men in their 20s. Like you said, you can go to, you can get some cocaine as quickly as, sooner than you order a takeaway. This should be something which is, you go into schools and they're talking about healthy eating and about, sexual health. This is a bigger part of that. This is about keeping you safe. And this is about, and I think you've got to have that conversation, not just around sexual health. You've got to have this, because the incident of young people taking that now is readily available, it's easy. The price as well, which is a factor. Years ago, you used to have to pay a lot to get drugs, but I think the cost of it now. And what's your view on what is the appropriate age to start talking about this? And do you think there should be more education in schools around this?
So education is definitely part of it. Samaritans work with Mind to shape the new curriculum for Wales, and we got at the top of that new curriculum a duty to promote mental health and well-being of young people within that. We've got to make that real now because it doesn't mean anything practically to teachers, and we've got to work with teachers to bring that to life in all kinds of ways. And definitely part of that relates to drug substance misuse work. It kind of links to the last question about the strategy too. I didn't want to say strategy. I was going to say the document that's being written. And it's an important document, but we all know that it's just a document. And what matters is what it instigates and what it delivers. There's always inevitably an implementation gap. The good thing about the situation in Wales is, we've got good leadership around this issue in government. And also it is a cross-governmental issue. So education is a good example of that. The reason we were able to get that in the new curriculum was because the door was open to speak to people in education side of government who aren't in the same part of government as health and mental health. And they are taking a cross-governmental approach, which is really encouraging. It's also the reason that we see, recently we're looking at things like means and access and looking at the rail network, that we've had really good conversations around some of the work we do on the rail network and extending that to parts of Wales where that doesn't happen. So that gives me massive optimism that there is in Wales a willingness across government to look at all the risk factors now we address them. And should drug and alcohol be part of a new document? Yeah, of course it should, because we all know it's a risk factor. I mean, the co-alc thing, probably we need more work to be specific about that. I think we all know that. But drug and alcohol, yeah, absolutely. That has to be. How can you have a strategy, a document that seeks to set the tone for how the delivery of services, the funding of services reduces self-harm, suicide, that doesn't recognise that drug and alcohol misuse is part of that picture? So, yes.
That really, in terms of our team nationally, another role that we have got that again will be out within the next couple of weeks, they're coming out at the same time, is a children and young persons or an education lead for our team, and that person will be looking at suicide and self-harm prevention of young people, but naturally suicide prevention will include the various factors and the various risks that might be faced by young people. So we will be listening, we will be hearing, and that person will be doing some work around children and young people to understand the impact of drugs and alcohol, and of course education will be part of that. My personal belief is that we should be having these conversations from a very young age, and I've always, and I'm talking out of my role now, but as a human being, as a mother, if children and young people are asking questions, then generally they're old enough to know the answers, given in the right way. So I definitely think that, lots of children are exposed to drugs and alcohol in various ways, through parents, through family members and so on. And I think it's really important that we are having those conversations from a young age. So we will be discussing that with our children and young persons lead. Thank you.
So if we go back to what Nicola and Paul were saying earlier, education is about parental education as well. So for me, when we look at that lived experience, if I was going to use, the person I would ask the questions for is the person I'm using with. The person that's closest to me is going to be my mum, my dad, my brother. We've heard stories. So I think there's almost something about broadening that education too. And if we look at the responsibility for teachers, I'm not entirely sure I would have wanted some of my children's teachers teaching around it, because they came home with a drugs are bad leaflet. So I think, yes, the education system needs an overhaul around it, but actually it's about who's delivering that training as well, because we don't want further stigma, which is obviously what we're dealing with in a community basis as well.
Can I just say that there was an amazing resource by the Daniel Spargo Maps Foundation, DSM Foundation, that have a really robust package of drug awareness lesson plans, and it is actually available free on the website, although I did pay for it because I appreciated what we were doing. I do feel that there's third sector
things that we could tap into. There are resources out there. And I think this is part of the lived experience, is that when we're looking around at things like that, we can bring these to the table for everybody to use. I mean, that's there, sitting there, free, and nobody's using it. And we could maybe get people into schools delivering it, or
and that's part of the ambition of the hub that we've developed as well, is that we can have a one place where we're hosting all of these different offers, and they're really easily accessible, because at the moment it does feel like there's these great things out there. Sorry.
I know, it's only because you're recording now.
Yeah, it does feel like there's these great resources out there, but they're dotted all over the place, and it's just having that one place where we can point people in the right direction and say, you know, here they are. Yeah, definitely. Thank you.
What's the name of that foundation again, Maggie? DSM, Daniel Spargo Map.
I know we're quite strapped for time. I know you asked for a question. Was someone by here ask as well? How many people was that? One of the questions, just so we can fly through them. Do you want to do yours first?
Yeah, I can do. It wasn't too dissimilar to what this lady asked here. But I work in uni. I'm a nurse as part of the health and wellbeing set up here, which is really robust. But first of all, we don't see enough of our students. They probably all are struggling. Not all of them, but quite a few of them, and they don't come forward. So that's a worry for us as a team. We do try to reach out, but they don't always come forth. So just wondering if there's any ideas in the room of how to break the barriers down there. But also, I'm a local girl, live just up the road, and big rugby community. And I know that within the rugby community itself, there is a huge problem with cocaine and alcohol. And I'm just wondering if there is anything out there, any outreach teams that are going into these places, into 16-year-old rugby club youth teams, and chatting about the risks, the real risks, because sadly I know somebody has died who's close to my family and my heart of not through suicide, but with cocaine and alcohol. It hasn't stopped the boys. They're still doing it. So I'm just wondering if there is any team or any kind of outreach that can go into these clubs to provide the education.
How I got started on this path. In your packs, there's the CSA signpost leaflet, and it started off, and that's how you contacted me, isn't it, over that? And I, because of the issues around male suicide and one thing and another, and I am actually, am I allowed to say I am a sort of undercover Samaritan. I was a Samaritan. I was very active Samaritan, and I was going into the community delivering educational resources and they're working with compassion. And actually, the work that I did on the leaflet in the pack is as a result of what I was hearing in the community that I couldn't do through Samaritans because Neil wasn't there then. And the aim of the leaflet is to go into barbershops, tattooists, rugby clubs. The problem is that I'm just me, and
I was just going to say that.
It's having enough of the people on the ground or being funded to resource that to be able to get it out there. I mean, I'd love for that leaflet to go in to every single thing, because the engagement we did on it, didn't we, was huge. And when we spoke to so many people, there was over 50 organisations that actually contributed to it when we were doing it. And then it's evolved since the original edit, hasn't it? Which I might just say at this point, if anybody does want any packs of these, I've got packs of the leaflets, the handout cards, the beer mats, and the posters. If you want them to put them on the back of pub doors, I hardly go out anymore, so I don't get to go any. But I suppose it's maybe this movement of what we're creating is getting the volunteers to say, yeah, I'll take a pack to my local rugby club, and hopefully that might do it. And I'm always offering free workshops online, don't I? which again, if you contact me after this and you want a workshop, I'll do it. You know, that's I can do that for you. So.
Go on, you can also.
Again, lived experience. I think people going in, like how the guy spoke earlier, them going in and speaking about, you know, drugs and alcohol. I think, you know, the young people do take notice. A few years ago, my son went to Ibiza on a stag, and somebody had taken kind of like a load of pills and hadn't agreed with their bowels, and they were walking around Ibiza with like stained shorts. And he was telling this to a friend of mine who's a teacher, and she said, I wish you could come into the schools or go into these clubs and tell the children those experiences of taking drugs that you'd be potentially walking down Ibiza Street with, you know, when you follow through. And I think that's what it needs to come from, you know, and the other side of it, it's not all great. And
one of the things, there was a group that I was focusing on trying to get here today, the Lost Boys Foundation, if anybody's heard of them. They're a barbershop based in Ponty, a free plug there for them, but basically they came out and they did a massive article in Wales Online. And what I think is the problem, and because he wouldn't engage in this, because they had so much vitriol for people online, say, oh, you know, you get what you deserve, and that is such a damning thing. And it's not, and what I was going to say before, it's not just damning for the people who are taking it, but it's also for the people who are wanting to access help.
Yeah.
We had a published article with Lucy John in Wales Online last week. She's been contacted by about 3 people. I've been contacted by 2. One, with a 17-year-old boy, they don't know what to do with him, you know, and yeah, we want to help and we want to save these people, but I forgot what the point was.
He was on about Lost Boys and how they didn't want to promote because
I think
they
it's
were
a
scared of
stigma. Yeah,
backlash.
it stops people. That double stigma stops
100%.
people like yourselves from accessing the help that you need in the downfall because of the judgment that you're in fear of getting. So it's a double stigma. It's not just on the boys that are the people. Sorry, anybody that's taken it. It's also on the parents because they're and you feel bad enough as a parent as it is.
But it can happen to them at any moment.
It can
That's the
happen,
saddest thing,
and it
really,
happened
isn't
to me. And you know, I took a different stance on it. I didn't know what to do. My peers were telling me something, and it was going against my instinct. And this is why one of the things we've got funding for is the Ask Kathleen site. So hopefully, with everybody's help, we can develop that in the future, in the near future as well. So, yeah, that's
I just answer Louise's question with no recent experience with me. I work like my counsellor. We did a project recently on men's mental health.
Yeah.
Took it all that a lot further as well, you know. And we work quite closely with WRU, and they've got fantastic safeguarding wellbeing leads on there. And they have that work with anyone with issues surrounding rugby clubs specifically. What we were finding is we were contacting the rugby clubs and they weren't invited volunteers in it. So we were there all the time answering emails. So we went straight to the Awesome Monthly. And WRU was fantastic. And they got a way in to all of the clubs. So in Wales. So you contact them. So giving them it's excellent.
Yeah, thank you. Thank you.
Hiya, Julian John. I work for Mind in Wales. What a inspiring event! You know, thanks to you for your stories, and you know, to the boys with the lived experience that have just been amazing. It's been really inspiring to be here. I have 2 questions really. One is when Sean's dad talked about losing a child. And the trauma and distress and the access to just being able to reach out, talk and access a compassionate listening service that isn't in any way medicalised or provided by the NHS. My question to the panel is, you know, where does this sit? Is it reconfiguring NHS services to provide emotional distress support to people bereaved by suicide? Or should we be leaning more into organisations like the Samaritans that do an amazing job in that space? Is it a clinical role or not? And being an advocate of the charity sector, for me, it would sit in the charity sector. That would be my first observation. So really interested in your views on that. And Kerry, why should we get excited about the iteration of the next strategy when we don't know how effective the last one was?
Thank you. Great questions. There we go. Good luck.
I found your second question so shocking I can't remember what the first one was now, Julian. So I'm going to answer the second one first, if that's okay. Actually, I think, all joke aside, it's a really reasonable question. I think in terms of why we should be excited is because we are going to give lots and lots of opportunities for individuals and groups to be able to be part of this new strategy. So we will be looking at the old strategy. We will be seeing where we can, there were some interesting times during that strategy, including COVID, that, changed a lot of things for a lot of people. But we will be looking to see, which bits were effective, which bits didn't work as well. And what we will be doing for this new strategy is making sure that we're listening to people, we're hearing. And that's the reason to get really, really excited about it, because your voices will be heard and hopefully will be part of that strategy. Cute. It's like a politician's answer, isn't it, I'm afraid?
Do you want to dive in on that as well? Yeah, brilliant.
So the answer to the first question you asked was in the question, because I think you said, should we be reconfiguring NHS services?
I think it was on the back of
the
doctor said in terms of some of the barriers and, sometimes people just need a response to an emotional distress. They don't need a clinical intervention necessarily. It's not, your experience, incredibly traumatic, but doesn't require a clinical intervention necessarily. It just requires someone to hear what is going on. And that might not sit in the NHS.
It's just something to say, and actually say, I think you'll be all right. And I'm just following on from Chris, because, rightly or wrongly, you first experienced cocaine at your mum's funeral, experience of grief.
You're right. Are we sticking plasters on the end result, or going back to the education, because that was my question? Young children, are they really going to listen to a live person? Is it going to stick with them? I think rugby clubs, as you get older, that's where people like this who are brave enough to speak probably hits them. But it was just that there's other things that are causing people to turn to drug and alcohol. So I just wanted to follow on. To me, it was a grief situation, and you were vulnerable.
Yeah, vulnerable is the thing.
Yeah.
Was it another thing? You put your hand up earlier.
It was
that,
yeah.
Brilliant. I did see someone else at the back. Was there someone else? Yeah, sorry. Sorry, mate.
Come on. It's Maggie's gig, but we're on the bill. I got to answer that question as well, because it was look. I'm obviously going to say the Samaritans offer that human service, and other people do too. So I don't know if you called the Samaritans, but either for people who are having a tough time, and not all of our calls are related to suicidality by any means, but even in a bereavement sense. And there's other organisations, people like Cruise, for example, and many others. So, and there's a massive place for them. And are we supported enough? Are we funded enough? No, of course we're not. Of course we're not. Because the instinct is always to reconfigure, to do, the reason I said reconfigure the NHS is I'm sure everyone in the room hearing those words can imagine what that is like. Reconfiguring anything in the NHS. It doesn't sound straightforward, does it? It doesn't sound like something that's going to happen in a week or a month or a year, or maybe even in a decade, because it's really complicated and because we all know our public services are under massive strain. So that's not to say the NHS and public services don't have a massive role in all of this. Of course they do. Of course we, if you turn up at your GPs and you say, I am thinking of taking my life, you're not going to get a great response in most cases. And we can't really pretend that we're taking this issue, suicide prevention in a broader sense, seriously until the answer to going to your GP or a primary healthcare professional and saying that is met with a really robust response. And the evidence is all out there about what that needs to be, you know, suicide safety plans, immediate referral to appropriate therapeutic support and so on. That doesn't exist. And until it does, we need to keep reminding people that it needs to exist, because it's a bit of a joke otherwise. But the state statutory services are never going to be all of the answer in all of this. How could they be? This is human stuff. You know, this is human stuff. It's not all clinical. It's not all medicalised, particularly in the context of bereavement.
I think for us as a service, we look at it as more of a person-centred approach. So what that person wants. So if somebody comes to us, they might want that one-to-one counselling, or they might want just to chat to someone, or a walk around the park, or walk on the beach. So I think it has to be person-centred and around what that person requires. Because some like it in a clinical setting, some prefer to go to a walk. That one-off single kind of therapy session is enough. So I think it's really listening to what that person and their individual needs are.
Yeah, and just on the back of that, our insights exercise that we did really told us that. So people talked about that humane, compassionate response that was coming through, you know, throughout that document. And if it's all right, Nicola, I wanted to use an example that you gave me earlier around supporting an individual. And I just really want to, in using this, just acknowledge what, you know, the third sector brings to people in Wales. And certainly I can speak for South East Wales. I rely really heavily on our partners, you know, for Tom, Jacob Abraham Foundation, Project Speak, Papyrus, Samaritans, you know, I could keep going on and on. But the example that you gave me earlier, Nicola, was somebody where, and hopefully it's all right to use Bryn's name, Bryn arrived to support a family, and the person said, I'm sorry, I can't offer you a cup of coffee because I don't have any coffee. And Bryn was able to say, actually, I've brought you this care package and you can give me a coffee. And just that it's that stuff that people tell us makes the huge, huge difference. And I think that support is very different to the support of statutory services, and I think there is an absolute need for that, and you know, and we really need to support our third sector in doing that.
One last question, right at the back. Yeah,
We're coming.
I think that's the thing as well. The services are there, like the support is there. We just need that better partnership working. We just need to kind of work the pathways, and that's where that kind of professional troublemaking comes in. If you're making referrals and they're refusing to see your money,
After the thing,
that's where that comes in as well.
Yeah, so I've kind of gone off the trail a bit now because so many things have been said, but I think we can all agree in this room that substance use issues affect all our communities. In Cwmtaf Morgannwg University Health Board footprint, I manage an out-of-hours crisis service. It's the only one in Cwmtaf Morgannwg, but it's only for the population of Bridgend at the moment because of funding. We accept referrals for people with substance use issues. We see quite a high number, especially young men, coming in for support around substance misuse issues and how it affects their well-being and their mental health and their home life. However, that steering group, we've got a fully functioning steering group for that service that includes health board managers, Bridgend Social Services, South Wales Police, third sector, and yet there's nobody representing substance misuse issue services on that steering group for that service. Secondly, I would like to see people like the guest speakers today. They would be ideal to sit on steering groups to design and co-deliver these services to meet the needs of those people. It's all very well being paid staff on a steering group. If you've never had that lived experience, how can you possibly design a service to meet those needs without listening to those people?
I'm going to add, it's not actually my place to add, but I'm going to add if that's okay. So we just rewritten the core standards for the drug and alcohol sector for the Welsh Government, and there's a whole section of lived experience right the way through all of those standards. They've literally been up and completely changed, and expert by experience is quite strongly expected right the way from
I agree.
strategy development, governance and compliance, quality assurance.
I agree.
Through to delivery as well.
But I think sometimes we talk about it and it doesn't happen enough on the ground. I mean, the guest speakers today, I mean, 2 out of 3 said they were hospitalised in a mental health hospital. Those guys are the key to joining up substance misuse services and mental health services. I also think there's some responsibility on the way services are commissioned. For example, sometimes they commission us to work in silos. Whereas if we had a different approach to the commissioned services, like an alliance commissioning, where drug and alcohol services organisations and a mental health organisation a joint commission to deliver one service, instead of, if you've got alcohol issues or drug issues and mental health, you might have a support worker in a substance misuse organisation, another support worker in a mental health organisation, and neither are working together. Housing, yeah, and a probation officer maybe, and nobody's talking to anybody.
Was there a specific question you wanted?
Oh yeah. Yeah, sorry, I'm not going to say the word strategy. I forgot my question. Anyway, I voiced what I wanted to say. So sorry, I forgot my question. But yeah, I just needed that to be aired in the room, really. Sorry, thank you.
So the strategic frameworks are in place, there's governance in place. It's about that partnership working, and it's about that accountability and where that accountability flows. And I think it has to be free flowing. I think we do lived experience really well in mental health services and substance use services. I think as sectors go, we do that really well. What we need is, I think we have the evidence, and I know kind of Professor Gareth was talking about the evidence from an academic perspective, but in this room, we have all the evidence we need to create incredible services. What we need is just that accountability, because I do genuinely believe that everybody sat in this room wants to improve services, not just for people using cocaine and alcohol, but general mental health, substance use as well.
Well, we see that in Cardiff and Vale. That's what we are doing, but we're just not highlighting this cocaine and alcohol problem. It's other drugs we're highlighting. But you're right, lived experience needs to be part of design and delivery of everything that goes on in services. So you are bang on, I think, there, and I think everyone knows that anyway. It's just, yeah, I think cocaine and alcohol is just overlooked all the time. And just quickly, you were talking about the harm reduction part of it. Do you think cocaine and alcohol should be recognised as the one common denominator with the suicide thing? And I look at it as with benzos and heroin, you're going to get a high risk of overdose. And I think with a mix of cocaine and alcohol, you're going to get a high risk of suicide. That's how I look at it.
And we've seen that. So drug-related deaths by cocaine use is ×7 in the last 10 years. So we're seeing the data is there. So when we talk about needing the data is already in place. We know that there's 3.5 more cocaine users than opiate users. Yes, the risks are different, but what we've got to work better at is as services, and I don't just fall on substance use services, I fall on all services, we've got to get better at recognising suicidal thoughts. And as somebody who's worked in the sector for 20 plus years, I've been saying 20 years for at least 3 years now, I feel that when I was working and doing some sessional work and somebody said that they had suicidal thoughts, I literally went, I don't know what to do with this. So we kind of go, oh, I had training, I had suicide prevention training, that was probably 5 years ago, or we don't do enough of that refresher and making sure we've got the right skills as well.
Can I just add really quickly, sorry. I think listening to the lived experience we all have, like people, the message that I'm taking with this is most of the people, they don't identify themselves as substance users.
Or service users.
There's a lot of language being used that's substance users, service users. They won't identify as that at all, so they're not going to, like we pointed out, they're not going to go into these services. So like we're all trying to do in our team, and again, list of well-being, we're trying to make a real switch to a preventative model, which we all know, everybody knows that's what the NHS needs to do, it's just how on earth do it. I stepped away from the NHS 8 years ago. But it's how do we reach the people who don't know that there's a problem, that they have a problem, or they're at risk.
That's what we'll talk about in the workshops. So, yeah, not that I'm just thinking of time, that's all. We've literally got 3
You're under
minutes.
last minute.
I'm very sorry. I know we're short on time.
It's all right.
But I just wanted to highlight to everybody in the room today, and it's a plug for our service really. I'm here from CAN 24/7. We are the All Wales Drug and Alcohol Helpline. And I think we sort of fit somewhere in between that third sector and statutory organisation. in as much as we're Welsh Government funded, we're hosted by the NHS, but we offer a fully confidential and anonymous service where anybody, regardless of how they see themselves, can call up and get non-judgmental, confidential, human advice, information and signposting about any issue that they're facing in terms of substances, without having to formalise it, without having to be referred, without having to have any of those sort of formal processes going on. And I just think that that's really important that people in this room know about that service and know that we're here, know that we're there 24/7, and that anybody can contact us 24/7 for that. Really, as been highlighted, that need for that human approach isn't judgmental, that doesn't require that identification, and he's just going to get that advice in the moment.
I'm glad you added that. I think, well, it's clearly clear there's a bunch of services, Samaritans included, done 24/7. I'm coming away today thinking, how do you create direct human connection in the moments the guys are describing? Which, let's face it, in this room, like, I'm going to be completely unfamiliar to everyone in this room. We'll all have found ourselves in various situations in our lives where we need that connection, whether it's related to substance misuse or anything else. You know, it's probably easier for you if you'd called your dealer, would have turned up in 10 minutes. You'd have had some human connection there, the wrong type. But, you know, there's a problem there in terms of a helpline's one thing, and obviously Samaritans, that's what at the heart we do. But in those moments of crisis that we're describing today, where you're not, I can admit this as a Samaritan. Are you gonna think in those moments, I'm gonna call that number? Well, I'm thinking, right, you need to put the Samaritan's number next to your dealer's number in your phone and all that stuff. But realistically, that actual human connection, the being with your mum thing, the having somebody and recognizing that they're there, how do we create that to avoid in those crisis moments? I think it's bloody difficult, but it's where we need to be aiming to. And some of the solutions are actually, they're not in the third sector, they're not in statutory services, they're amongst friend groups and peer groups. It's all that stuff. Like, you've got to some of these realities just come down to our responsibilities to each other.
Can I just ask one question and then I'll shut up? Do any of the boys...
Mike, you are.
Do any of the boys that you spoke this morning, if you'd have known that on the come down it would have made you feel suicidal, would that have made a difference? It would. Because this is about awareness now, isn't it?
Yeah, for sure, definitely. If it's just like a lot of drugs, if you know what's going to happen, you can prepare for it. If you drank alcohol and you didn't know that people throw up, and then you're throwing up in the toilet, it'd be terrifying. Yeah. You'd be like, why can't I stop myself from throwing up? This is absolutely terrifying. But everyone knows you might throw up if you drink too much. But I was going to touch on a point of how do we get to people when they're in a moment of crisis. The thing is, I've met people that are in recovery, and a lot of these people, 15 years in recovery, they're still going to the sessions because they need it. They need it as a tool in their life, and it's not. And they continue to do it when they feel good. Every time they go, I feel great this week. I've been doing this. I feel great this week as well. And this week I feel great. But they continue to use it because they see the value of it. But you're trying to get people in a moment of crisis. If they haven't been going before that, you're not going to get them. They're not going to go in. That's the person that uses that kind of support group as a tool. They know to do that in a moment of crisis. But maybe if you can get some people just sitting around talking, and it's a normal thing, not like a thing where, oh, now I'm having a moment, so I need help. Everyone always needs help. So why don't you set something up, or I don't know how you do it, but just kind of have a way to implement this. I'm not saying get loads of kids and talk about drugs, but get loads of kids and have them all talking as a practice that always happens. So when they are in a moment of distress, they have the tools. Yeah. And you're saying, oh, but the tools are there. There's support groups. But it's not. You have to learn how to use a tool. You can't just give someone a tool and go, there you go, this will fix you. Yeah.
Last one.
Yeah, just to add to that, and I'd like your view if this would be helpful. So what we do as part of our suicide intervention and prevention with people in crisis, or when people come into the service for support, we get them to create their own safety plan. So when they're in a crisis, so part of that safety plan would be human contact. Who could they contact? Is that a friend, a family member, somebody that you could speak openly about suicide? Someone who will be there, maybe getting 2 people like that. Then we get them to put in, we always get them to put the Samaritans in, or Dan to a helpline number, so there's somebody else they can speak to there. And looking as well, what's helped before, what's got you through before, what's helped you, whether it's music, whatever that is, a walk, whatever that is. And I know that the therapists sometimes, when they're working with someone, they refer back to your safety plan, and that's worked. Do you think if someone would have sat down and got you to create your own safety plan for when you were in a crisis, do you think that would have been helpful, that there was...
Maybe, but for me, I think it's still the kind of, it's like you feel like you're creating a safety plan because you expect something to go wrong or something like that. But something going wrong is normal, so it's not actually wrong. So if you can get people earlier than the idea that there might be something about you that makes you have a tendency for things to go wrong. So that's why you're here. Everyone is here all the time, and so. Like if somehow kids could manage to be in a support group all the time throughout school and college and then uni and then after that as well throughout their entire life, because I think support in general, you need support, everyone needs support. So the fact that people don't have support, it's difficult to ask for it because it's a strange thing that they've never had. So they have to have already had it for their whole life to then see that as a place to go. So that's, yeah.
Thank you.
I want to give a thank you to the panel again, maybe. Another round of applause.
Another round of applause. Panel, please.
Thank you. Okay, so we've wrapped up today. We've had a great day here, really inspirational. We started off this morning with the bereaved mothers, with Nicola Abraham, Nicola and Paul. Then we started the afternoon off with the lived experience, which was my personal favourite, really hard hitting. And then we just finished off with the professionals, some of the Samaritans and other organisations. I hope you enjoyed today. I really think cocaine and alcohol are killers themselves. But together, it's just a ticking time bomb, and we need to raise more awareness on this. And I hope you enjoyed this podcast, guys. It's a bit different. There might be a few blips and errors along the way, but hopefully we've brought you something that's wholesome and, something that's worth listening to. So thank you so much. Make sure you subscribe to the club and stay central.
The Central Club.